Good Thursday night, and thank you for joining us tonight on Newsroom Africa Channel 405. The chairperson of the Portfolio Committee on Health, Dr. Sisonke, says it's obvious that COVID-19 protocols have largely been ignored as large crowds gathered to mourn the late AmaZulu King Goodwill Zwelithini. Scores of people came together to celebrate the king's life on the streets around Gwakheto Mthandayo Royal Palace in Nongoma, KwaZulu-Natal. Now, some were seen not wearing face masks, and there was also no social distancing. Shomo says this has posed a potential health hazard over the past few days.
Where there's been pleas, and you know that each time we try our best, we continue asking, pleading with people to say, look, do this, social distancing, not big crowds, wear a mask. But yes, we continued giving those messages under that type of a cloud of everybody wanting to actually see and be next to Gwakheto Mthandayo. So yes, we continued, even during the ceremony, during the memorial service today, Umntwana uQedi spoke about this matter. So look, this is a social behavior plea that we continue to do. We are concerned, and the king would have been very much concerned to find people not really wearing masks, social distancing, but the situation was just too much overwhelming to the citizens of our province.
Meanwhile, scientists are warning that the third wave of COVID-19 could hit the country as early as the beginning of April, with the Easter holidays imminent and gatherings set to increase. And to help us unpack the drivers of the third wave and possible ways to prevent it, I'm joined by the Acting Deputy Vice-Chancellor of Research and Innovation at the University of KwaZulu-Natal, Professor Musamo Shabela, and Wits University Social Security Systems Administration and Management Studies Chairperson, Professor Alex van der Heever. You can be a part of this conversation. You can tag us right now as Newsroom 405. WhatsApp us your questions and your comments on 072-110-5584. Gentlemen, good evening and thank you for joining us tonight.
Good evening.
Prof. Alex, let me start with you. What's your level of concern on a new surge?
I think it always remains high. I think the lesson that we've learned is that this is we will not only experience surges of the epidemic during winters, we can experience them in hot weather as well. And therefore, a large part of why we experience these surges and waves is because of human behavior. And it's quite clear that the experience in November, December shows that when people felt relaxed because restrictions were pulled back, that in fact it was okay to behave as they did prior to March 2020. And in fact, if that happens, we will have super spreading events, and then we will have an upward trajectory driven by multiple super spreading events until we introduce new restrictions. So this remains a concern, and the ambient level of infections from the sort of community-based transmission remains relatively high, even at this sort of relatively low point of the in this period. So it can basically light up at any point.
Of course, what we saw around December is that tin roof event, which, of course, was classified as super spreader event. And out of that, cluster infections began to emerge, and those quickly spread throughout the country. Looking at this unforeseen event of the passing of the king this past week and the gatherings and the events that ensued thereafter, would you say those could qualify as a super spreader event?
Yes, it would. It's a very, very high-risk event. Although if people are outside, the risk of transmission is lowered. But if people are in very close proximity or go into any indoor setting, the risk increases considerably. But in general, it appears as though the way in which the crowds acted was just relatively incautious, which means people are feeling safe when in fact they're not safe. And I think it's that feeling of safety that is actually a very big risk. People should act as though the person next to them, if they don't know them, is infected, and manage their behavior accordingly. I don't think we should always just look at the level of restriction in how we conduct ourselves. We should actually be very, very wary about the risks of in any setting with crowds.
Professor Shabela, what's your level of concern around a possible new surge of infections?
Yeah, greetings, Thabo, and to your viewers. I think that because we are approaching Easter weekend, that's where my concern is at the moment. And I guess my concern really is not that we are approaching the weekend. That's going to come whether we like it or not. My concern is we're not really having an open discussion about how we are preparing for that and how we are going to limit the risks that would come with social gatherings. I think that any gathering is going to be the biggest risk as a trigger for a third wave. I think somehow people just have to remember that, in as much as we don't want the third wave, we have to recognize that gatherings are going to be spreading events. Any gathering, and some gatherings may not be avoided, but many gatherings can be avoided. Yeah. And some gatherings, it may be difficult to put in place measures to limit spread of infection. But for many gatherings, we may have to try and find ways of making sure that we limit infection, the spread of infections. What I would really like, Thabo, is for us to have an open conversation about how we are avoiding a third wave collectively as a country, not just at an individual level.
Yeah. Now, looking at our communication globally, what lessons have we learned? I'll ask you why. I'm telling you why I'm asking you that. For example, we're seeing Italy already beginning to lock up again. And if you look at the time in which they had opened up and the possibility now that they're going to a third wave, the duration of that period and possibly the duration of the period that we have been opening up our industry and whether or not it would have coincided. But also in terms of the rate of a decrease in infections, if you look at the U.S., Dr. Anthony Fauci reporting that they had a significant drop in the number of new infections. However, right now when they look at their graph, that graph has plateaued, which in itself, he says, is a risk and a concern that a possible resurgence could be on the cards. What is your feeling when you look at that data and how we are, of course, communicating with what's happening throughout the globe?
So, for me, I think that on the one hand, I am actually pleased to listen to conversations and have conversations with people and watch conversations unfold in the public where people actually recognize super spreader events and they're actually calling for safer measures. On the one hand, I see that. And I think in a way, those people who are engaging in those conversations have to be commended for that. But on the other hand, we are also having other conversations where people are still denying the risks. They're still continuing with conspiracy theories. And it is actually disappointing to actually see those conversations after we've been through the first wave and the second wave. And actually currently, as you say, when we are watching other countries like Italy and others that are already experiencing third waves, somehow it's almost as if we still think ourselves immune to the risk of a third wave. And yes, we do kind of cope with by being comical and with comedy and jokes. But actually, this is too important to actually joke about. It's really important that we need to actually say that the risk is real. And now that the risk is real, what do? We shouldn't be having a conversation about, whether this is a joke or whether someone is controlling the waves or who's lying to who and whether there is any conspiracy here. We just need to be able to get to a point where we speak in very specific terms around how we are preparing for a third wave or how far we can go in trying to avoid a severe third wave. Yeah. As you say, globally, we are seeing that the pattern is there. We don't have enough coverage of vaccines for us to actually think that we can count on vaccines in order to limit the third wave. Hopefully, we can be able to protect the integrity of the health system enough by vaccinating as many health workers as possible. Yeah. But as a society, we have to face this risk and actually prepare for it.
And that's where I was coming to next, Prof. Alex. Knowing that healthcare workers in the country, for example, suffer twice the COVID-19 infection rate of the communities which they serve, what lessons have we learned public health-wise that will put us in good stead come the third wave?
I think that frontline health workers have been placed in an incredibly difficult and dangerous position in this pandemic. We haven't really prepared ourselves to protect them and health facilities adequately, but we've also not fully prepared the health facilities for the kinds of surges that we've experienced, some worse than others. But I think that we are going through the process now of at least vaccinating the frontline health workers, although it's not entirely clear that the frontline health workers have been prioritized relative to other people with health qualifications who are not in the front line. And if we were focusing purely on the frontline health workers, we would actually be vaccinating more of the people who are going to be at risk and already are at risk in the hospitals. So I think it's good that that they are vaccinated, but this is not our rollout strategy. This is a workaround. It's an expansion of the Johnson & Johnson trial. And we are still awaiting a proper rollout program in South Africa. And unfortunately, we really do need it. And we seem to be tripping over our feet on getting ahead on this. We should have been far, far further forward in vaccinating the high-risk population in South Africa before we go into another surge. And unfortunately, that wasn't adequately prioritized in 2020. So we are going to have to prioritize protecting our facilities again from a surge of patients, because if the behavior continues as it is now, we're probably going to experience another surge relatively within the next month or so. But although there is uncertainty around a number of factors around that, it's a very probable scenario, even if it doesn't occur, but it's a very probable scenario. But will be a very unfortunate one if it happens, because it's so difficult. With our tracking of the epidemic, we're effectively only identifying the position that occurred 3 weeks ago. So by the time we start to see the surge pick up, we're already 3 to 4 weeks into it. And that's the problem, because the hospitals are being hit when the new infection data is only just coming out. And that's part of the reason why we don't have a properly prepared system each time we get a surge.
All right, we continue for you next year on the news feed late night. Professor Sisonke and Professor Alex van der Heever, they stay on. You can be a part of the conversation. Tag us now at Newsroom 405. WhatsApp your questions and your comments on 072-110. Welcome back. A conversation tonight on a possibility of a third wave. What is the thinking? What should we be doing right now? What have we learned in the last wave? And what are we not doing? Acting Deputy Vice Chancellor of Research and Innovation at the University of KwaZulu-Natal, Professor Sisonke, with us in this conversation, and Wits University Social Security Systems Administration and Management Studies Chairperson, Professor Alex van der Heever. Professor Sisonke, let's talk then exactly about what you think the conversation should be right now, right? It coincides possibly with the Easter holidays. What is the thinking around the prevention?
Yeah, no, Thabo, it's a difficult one. We just came out of the second wave, and in many ways, you know, our society thrives on social gatherings. It's so unfortunate to have to admit that, but that's the reality. If you look generally, churches thrive on social gatherings. The groove community thrives on social gatherings. A lot of the education sector thrives on social gatherings. Business thrives on gatherings. A large part of our society thrives on gatherings. And so we understand why there is so much pressure to go into a state where we can engage in gatherings. And I think it was a relief for people to go to alert level 1, knowing that they can increase social gatherings to some extent. But the reality is that this is a risk for the third wave, especially if we carry on with it in a way that we are doing currently. It's really going to be a combination of events that are going to trigger a third wave. And most people understand this and know this. And most people, I would like to believe, they are trying to do their best to avoid this. But the reality is that a lot of the gatherings are emotional, gatherings that are not necessarily logical for a lot of people. So like right now, over this past week, in terms of the mourning of the loss of the king, it's something that's difficult to tell people to be rational about, because it's a painful event for them. They are willing to face the risk. If you look at people who are going to parties or people who are going to church, it's very difficult for people to be rational about the risks that are concerned. But Thabo, we have to, as much as possible, prevent this. And I am hoping that government will be able to roll out vaccines so that this is perhaps, hopefully, the last time people have to sacrifice this much. But we have to sacrifice. And if we can coincide this with a good rollout of vaccines as government has promised, I am hoping that whatever restrictions we put in place, and we have to talk about restrictions, whatever restrictions we put in place, we can put them in place early enough, so that we can limit the negative impact of a potential third wave.
Still on vaccines, do you feel that the vaccine goals set are achievable, considering after the AstraZeneca debacle, there is no realistic option that actually has been put on the table, except for, I suppose, means and negotiations that are going on with various vaccine providers?
So far, the only vaccine that we really have agreed on and we have a consensus on is the Johnson & Johnson vaccine. That's pretty much the only one we have a consensus on. And the reason I say that is because the registration of the Pfizer-BioNTech vaccine comes with a condition that it still needs to be monitored locally in South Africa for both safety and efficacy. And that is because it was not really tested in South Africa. The Johnson & Johnson vaccine was tested in South Africa. So there's a lot more confidence around that vaccine. But on its own, it's not going to be enough to be able to to achieve the coverage that we need in 2020 in order to avert further spread of infections. But if we are going to go with Pfizer, which we are likely to go with, it's going to be a slow rollout from the Pfizer perspective, because the requirements for monitoring are going to be much stricter than a vaccine that does not have the level of restrictions that SAPRA has attached to Pfizer. And as you said, pretty much AstraZeneca Oxford vaccine, we have eliminated it as an option in South Africa. Even if government was to try and bring it back, it will be very difficult to convince people to take it after we've...
I suppose the noise around it that we have been hearing from over 24 countries now, even though the EU has now recently just issued a statement, I believe, that says it is safe, doesn't seemingly cause any blood clots. We're still awaiting the World Health Organization to issue their statement. I'm saying even with that kind of noise coming out back and forth, that is no longer an option on the table for us as South Africa.
We've stigmatized it. It should be an option. It should be an option. But we have stigmatized it a lot. And I'm impressed by countries like Australia. They are going ahead with it. They did not necessarily allow themselves to be distracted by what was happening in Europe. But even in Europe, it will be difficult for them to convince their people to take the Oxford AstraZeneca vaccine after how it's been treated multiple times, repeatedly. It was not once. So in a way, I think that even though it can still be on the table and government says it's still on the table, the reality of the matter is that we're going to have a hard time convincing people that it's okay to use it.
Prof. Alex, the health minister initially predicting 1 million vaccines by the end of the month. Is that goal achievable?
No, it would have been achievable if we had rolled out with AstraZeneca, just to sort of clarify that point, I think South Africa made a very poor strategic decision not to continue to roll out. I think it was the correct decision to switch to Johnson & Johnson for frontline healthcare workers, because they really do need to be protected against the South African variant. But because we will have a shortage of vaccines during this period, and we don't really have any alternative, it would have been better for us to have utilized the up to 3 to potentially 5 million AstraZeneca doses that we could have got during this period and just got a rollout program running. We can, at a later stage during the year, we would have been giving booster shots, and potentially people are mixing the different vaccines in that you can have an alternative vaccine as your second shot, and would offer you very good protection potentially. So I think that those strategies meant that you vaccinate with the doses you get. All the vaccines that have been approved around the world are worth taking, and they will provide some degree of immunity, even if it's not absolutely perfect against all variants. But that's going to be the case down the line. So we've lost that chance. But I also think that the reason that we didn't roll out with AstraZeneca was because government wasn't ready to roll out. It hadn't done the ground game right. There weren't the vaccine sites sorted out. The private-public cooperation wasn't done. So they were sitting with a position where they couldn't actually get a rollout going, and I think that's a big problem. We need to get that ground game done immediately, so that as we get doses, we can actually distribute them as quickly as possible into the population. The current vaccination program is an expanded pilot arrangement around existing pilot sites, which is too limited for a rollout program.
While we talk of the possibility of more variants, I mean, scientifically, what are the chances of us going into a process as we go into the third wave of seeing more variants coming up?
I think the variants are going to emerge. The question is really whether they completely overcome vaccines or historical infection. South Africa's experienced actually quite a severe epidemic. There have been a lot more people infected than are recorded as infected. A lot more people have died than have been recorded as died. But the second wave was larger than the first wave. And the evidence appears to suggest people who were infected have greater immunity than from the first wave. So there is a natural immune effect there. I think the vaccines add to that immunity level down the line. So I think it's not entirely clear that the vaccines are going to completely overwhelm the virus is going to mutate and outrun the vaccines or historical natural immunity. I think that we will build up progressively levels of immunity that will slow the severity of the disease over time. There are arguments that we will not completely eliminate the virus as we have with flu and other coronaviruses, but the virus as we go forward will not produce the mortality rates that we have now. So that's the trajectory we're on. So any attempt to build up our immunity will help against severe illness, even if we do get infected.
Professor Moshabela, there is a lot of noise around our risk priority verification process for healthcare workers. In fact, there are those who are said to have been bullying the vaccinators around this particular process. Are there any faults in that process that we need to look at, and maybe the more stock we get, improve on that process?
Yeah, and I think here again, Thabo, it's important to make it clear that the processes we have in place are not necessarily government processes of rollout. They are still the implementation study phase 3B processes. However, what we have picked up is that actually there may be variations in the way the implementation is unfolding in different provinces. And there is a little bit of inconsistencies from what we are hearing on the ground. And for us, we were expecting that there will be a clear list of people that have to be vaccinated, and that list will be followed according to the order of priority. But it has been disappointing that people have been able to interfere with it, and some people have raised concerns about the fact that at the end of the day, when when there are leftover doses, they just pretty much call anyone who is immediately available to come and get vaccinated. And those kind of processes create loopholes. And those are the kind of things I think Alex is also referring to as having your plans in order on the ground and having a clear plan of what you're going to do practically. And so it would be good, Thabo, if these variations can be cleared. You know, you get one clarity from one province, and then you get a different story from another province, and that makes it difficult for us to be able to kind of vouch for the integrity of the processes that are put in place. And it takes one or two incidents to actually discredit the processes, and we cannot afford that.
When we continue here on the Newsfeed Late Night, we're also going to be in conversation with Professor Linda Gale Becker, the co-principal investigators of the Sisonke study, and she'll give us the outcomes of what they've been able to achieve at this particular point. And that is, of course, the process that we are touching on here as far as the Johnson & Johnson vaccine is concerned. We'll continue in a moment with the acting Deputy Vice Chancellor of Research and Innovation at the University of KwaZulu-Natal, Professor Musa Mushabela, and the Wits University Social Security Systems Administration and Management Studies Chair, Professor Alex van der Heever. We'll take your thoughts in a moment as well on Twitter, as well as on WhatsApp, 072-110-5584. Stay with us. Welcome back. The Newsfeed Late Night continues for you here on Newsroom Africa, Channel 405, in conversation with Professor Musa Mushabela and Professor Alex van der Heever on a possibility of a COVID-19 third wave. We'll bring in Prof. Linda in this conversation as well in a moment. She's standing by. Meanwhile, Deputy President David Mabuza has painted a grim picture of the slow pace of the country's COVID-19 vaccination program. He says government is struggling to procure doses from pharmaceutical companies. The health department had hoped to vaccinate 1.1 million people by the end of March, but only 170,000 healthcare workers have received the injection so far.
No good news. We're still struggling with availability. Of course, Johnson & Johnson is picking up now, and Pfizer will come into the play. So in the next few weeks, we're expecting more vaccines. We thought by the end of March we'll reach 1 million, but doesn't look like. Probably the first week of April, second week of April, that's where we're going to reach 1 million. But as we're speaking now, inoculation is continuing, though not at a very good pace. I can say the pace is not good.
Mabuza adds that the second phase of the rollout, initially set to begin in early April, is likely to be delayed. Now, this phase will target 16 million people, including police officers, teachers, and senior citizens.
In terms of our plan, the first quarter, which is supposed to end end of March, we're going to deal with all health workers. Then the second phase will be starting in April. Then we're dealing with all other frontline workers, your teachers, your police. So I see us pushing back. Maybe the second phase might start the second week of April, because we must finish our frontline, our health workers, and we must reach that 1 million. That was according to the first phase. So far, we've inoculated just above 150,000. We're standing at 157,000 yesterday.
Now, more than 10% of South Africa's frontline healthcare workers have been vaccinated through the Sisonke study. Professor Linda Gale Becker, co-principal investigator of the Sisonke study and director of the Desmond Tutu HIV Center, joins me now to talk about exactly that. Prof. Linda, thank you very much for joining us, and we still have with us in the conversation Professor Alex van der Heever as well as Professor Musa Mushabela. But Prof. Linda, I'll start with you. Let's talk then about the 10% of healthcare workers who have been vaccinated. What is the impact of that number, and what are we learning as far as how we need to approach this mass vaccination campaign that the country should be embarking on?
Yeah, so 10% obviously means those, and in fact it was last night today we're on 175,000 healthcare workers. The way I see it, those are 175 healthcare workers who were not vaccinated a month ago. So good news for those individuals. But you're right, that is only a small percentage of people that we really need to reach. So still a long way to go. And the Sisonke program is providing at least some respite while we wait for those vaccines, as you heard from the Deputy President. That's the critical thing, is the supply of vaccines.
The feeling of being guinea pigs, does that still exist, or have you adequately addressed that as far as the study is concerned?
Well, I'm not quite sure where the idea of guinea pigs came up. This clinical trial was completed in January, the phase 3 of the Ensemble J&J. It's one of a number of clinical trials that have occurred recently to find vaccines for the COVID-19 problem. And we completed that clinical trial known as Ensemble, knowing that J&J is both efficacious and safe. This 3B study is really an add-on to look at real-world implementation of the vaccine here in South Africa. And so it isn't about deciding whether the vaccine works or not. It's more about learning lessons about a vaccine rollout. And I think we are learning some very valuable lessons that we're able to pass on to our national department and provincial departments of health on how to do the rollout when it does occur.
What information would you be passing on? I believe some of the vaccinators were complaining, for example, around the risk priority verification process, saying healthcare workers were actually bullying them, and the Sisonke people were not listening to them. Neither was the Department of Health around to address those complaints.
Well, I think the researchers are very much on site. Our mandate is to make sure that the vaccine is well handled, that it's drawn up in the syringes correctly, and that we hand off then to the vaccine trial centers. I think actually overall the partnership and the relationship has gone really well. This has meant we've been able to reach levels of 10,000 vaccinations a day. And given that we're only, 31 research sites around the country, I think it's been pretty extraordinary. So I must say, I think there has been very good partnership. The lessons we're learning is, yes, it is hard to kind of sequence people when you have a very rationed supply, and that's our difficulty. We don't have enough vaccines, and so we're trying to make sure they're getting to the most vulnerable, the most needy in the first instance, and that always leads to, emotions and trying to direct a rationed resource. But I think on the whole, I think the lessons we're learning is how to manage the vaccine centers in the most efficient way whilst maintaining quality. And those lessons are going to be valuable when we start to scale up. And there's no doubt scale up is going to be required if we're going to meet the numbers we need to do by the end of the year.
They've increased the centers, I believe, to 47 centers now. How has that improved the rollout, and what lessons do we learn from that?
Well, I think we went from 18 sites, as you say, to, around 40 odd. This means we've been able to go into more rural areas. And clearly, one of the big issues here is to be equitable, to make sure we aren't only in the metros, that we do reach our healthcare workers in more far-flung areas. And that certainly has started. So I know we're now in areas like around the Northern Cape. We'll be moving into Caledon. We've been in Paarl. We've been in areas in the Free State outside of the metros, Northwest Limpopo. That means that the researchers are having to travel the vaccines. So again, learning what it'll take to really get to 40 million. I think that'll be quite a challenge for the country. But I think the lessons we've learned in this first month are going to be valuable.
Now, the Deputy President is supposed talking about a pace, and I'm sure he's not referring really to the Sisonke study itself, but talking about a pace generally of having to roll out 1 million vaccines by the end of March, saying, well, the pace has not been good enough. I mean, if you look at the fact that the pace has not been great and the information that you've gathered through this study, what would you say needs to be improved to up that pace?
Well, I mean, the critical ingredient here is vaccines, right? If we don't have vaccines, we can't deploy them. And that's the absolute critical commodity here. We haven't really tested the vaccine rollout program until we have vaccines in hand to see how things will go. I know government does have a plan. There are a number of vaccine centers that have been registered around the country, many more than we are using now in the Sisonke program. And, I think once the vaccines roll in, let's give the vaccine program a chance to see how it can scale up. I think that's going to be the proof in the pudding, as it were, to see how well we can scale up once those vaccines are on hand. But for me, the big problem at the moment is the supply.
What is the benefit, Prof, of the fact that this vaccine is being tested in our country right now on our health professionals?
Well, I think it was a huge, important contribution that ensemble, the phase 3 of the J&J, did occur here. It meant that we had data around the performance of that vaccine against the new 135 a vaccine variant. We know that it did perform adequately in terms of combating and protecting against severe disease and death. And that's given us confidence to roll the vaccine out. Now, Sisonke, the 3B, it's an open label trial and is being directed into healthcare workers. We are monitoring the program very carefully, and I think it'll give us additional data on effectiveness. Now, what we mean by that is how well does the vaccine perform in a real world environment. And that's kind of phase 4 data. It's pharmacovigilance. It's looking for very rare events. If they are going to occur, we think the vaccine's safe. But it means if we roll it out to many more people, if there are some unusual side effects that we weren't expecting, we'll find that out in the next few months. And we will be able to do that because we're keeping a very close eye on the rollout. We're looking for breakthrough infections. I think that's very important. If we do see breakthrough infections, why? Is it because the virus is unusual or because we aren't seeing the responses in the immune systems that we expected? So I think this information is incredibly important to the rest of the world, as well as, of course, here in South Africa. It gives us confidence that these vaccines can be deployed and they are going to do the job we intend them to do.
Yeah. And when are we likely going to get that information, Prof?
Well, we're up to, as I say, 175,000. That's an enormous number. We know safety continues to be reassuring. So that's the first point. We are monitoring those breakthrough infections. We're heading for 500,000 healthcare workers. We'll follow them up for 2 years. I think the data is coming in as we go, and we will continue to update government, the healthcare workers themselves, and the vaccine committee as the data comes in the door. So far, so good. Things are looking fine, and we'll continue to monitor that and feedback as we go.
All right, that is the co-principal investigator for the Sisonke study, director of the Desmond Tutu HIV Center, Prof. Linda Gail Becker. We also still have with us the acting deputy vice chancellor of research and innovation at the University of KwaZulu-Natal, Professor Musa Mushabela, and the Wits University Social Security Systems Administration and Management Studies Chair, Prof. Alex van der Heever. We wrap up this conversation. Take some of your tweets when we come back next. Welcome back. The Newsfeed Late Night continues for you now on Newsroom Africa Channel 405 in conversation with the co-principal investigator for the Sisonke study and director for the Desmond Tutu HIV Center, Prof. Linda Gail Becker, the acting deputy vice chancellor for research and innovation at the University of KwaZulu-Natal, as well as that is Professor Musa Son, as well as Wits University Social Security Systems Administration Management Studies Chair, Prof. Alex van der Heever. Prof. Alex, as well as Professor Mushabela, here's a question for you. And I've got one as well on social media tonight for Professor Gail. But for you, the question is from Khaledisi, saying everyone is talking about the third wave of the COVID-19. Why are we still in level 1 lockdown if we know for sure that the third wave will be deadly? Waiting for big numbers of infections maybe? And later start to introduce stricter measures. What is the reason for waiting? This, by the way, as France is announcing that 6 French regions are set to go into lockdown for a month from midnight tomorrow. Prof. Alex?
So the the kind of one indicator that I look at is the excess death information, which gives a sort of fairly accurate reading of the epidemic. And what you're seeing is that the excess deaths per week have not dropped to very low levels. I mean, they're currently at levels about 1,700 per month. That's per week. Sorry, that's a lot. And then we're also seeing an uptick. So our risk is always prevalent. The problem is that the moment there is a number of key super spreading events that then takes off. So this is basically like putting a match in brush. At some point, if there are a lot of people who are susceptible to infections, if you have a number of super spreading events, you're suddenly seeding multiple contexts and you suddenly have a big rise. So it's always there, it's always ready. So the issue is really whether or not we have to have a better configuration of restrictions for our level 1 scenario and escalate timeously, not in a delayed way, when we start looking for the forward indicators. And just to note that there are a number of forward indicators that people are trying to get that are better than the daily infection numbers that we get, which are way too late. They are looking, for instance, at wastewater analyses, which give an indication of potential viral load in the community. And that's interesting, and that often tells you that there's a sudden surge or movement well before you will detect it in other indicators.
That has been, though, for a while. That has been for a while now, Prof. Are we using that information, though?
I only know that the Western Cape is looking at that information. I don't think that it's very difficult to know what government is looking at, because they seem to really be reacting with on the daily infection numbers that are presented, which really means they're working on a 4-week lag, which is way too late. It means we will be well in the middle of a surge when we start to react. And they will only be reacting when those numbers are high, which means, in fact, they've been high for 4 weeks.
Yeah.
So it is really way too late. So I'm not entirely sure what the reaction framework is that's in place for dealing with the surges, but we are definitely reacting far too late in the day.
And Prof. Moshabela, that's exactly the concern, isn't it, from that tweet, that are we waiting for those numbers to rise before we actually do anything about it? Are we reacting too late?
So if you look Thabo, at the second wave, that's how we reacted, and that was very clear. That we had abandoned any kind of modeling data, any forecasting data that was being produced, and we focused on the cases. And it's only when a district is considered a hotspot that we then acted, and that's too late, way too late. And so that's typical of being reactionary. But if you go back to the first wave, there was a little bit of acting early, but also at that time, the problem is we tended to overreact as well. So that balancing act was really the one that was difficult. And at that time, of course, what happened was that when you act early, then you avoid the kind of disaster that you are anticipating and you want to avoid. The impression it creates in society is that, well, there was never going to be a problem anyway. And so people feel like, okay, it was not worth the sort of reaction that you instituted early. So which is why in the second wave, government tended, in my view, government tended to wait until it's clear for everyone why they are reacting. But that's too late, because then that results with a lot of mortality and a lot of the problems that we saw in the second wave. What we need to do in the third wave is to strike a balance between those two, whereby we've got clear indicators with forecasting for us to be able to act at least 2 weeks before there's a problem, but also for South Africans to appreciate that prevention means that you're not going to experience the problems. And when you avoid that problem, it does not mean that the problem was not going to happen. It's the benefit of prevention. Now, we in South Africa generally, we struggle to work with this notion of preventing problems. We tend to work with this, we understand this reaction kind of approach that government tends to adopt. That's what, for me, I would actually suggest that the strategy government needs to take for the third wave is that of acting a little bit early with forecasting information rather than waiting for cases to reach a hotspots kind of scenario.
Prof. Linda, here's a question for you. It comes from Jacob. Jacob is asking, what are the potential consequences if one gets vaccinated today and later that day or a day or two later gets infected with the coronavirus? Would they need to be vaccinated again?
Vaccination we're offering at the moment is to prevent severe disease and death. We don't have a good handle on whether the vaccine has an impact on transmission as yet. It may do, we just don't have that data. And there's increasing data to show that it also has an impact on milder or even asymptomatic infection. The problem with getting the disease so soon after vaccination is that probably the immune system is not yet going to have been primed sufficiently to have an impact. When we look at the immune responses after vaccination, and I'm talking specifically about J&J now, which is a single-dose vaccine, we see some immune protectiveness within a week. We see more after 2 weeks, but we only really see full protection after 28 days. So we are appealing to people that if you've just been vaccinated, you have to act as if you haven't been vaccinated for at least a month. In other words, continue to practice your NPI precautions at least for 28 days when you can expect to have more immune protection on board. So that's important to know. Vaccines don't work immediately. There are very few vaccines that would do that straight away.
There you are, Jacob. Hope that addresses your question then. Let's wrap it up. Prof. Alex, what can we do to slow down the arrival of the third wave? I mean, already the Deputy President, they're almost admitting that they're having a difficulty securing supply at this particular point.
Well, we've had incredible difficulty in being able to prevent behavior from impacting on the trajectory, the absence of extreme restrictions, which is a problem. And I think that what really concerns me is that what's been indicated is that Aspen Pharmacare is going to export from South Africa 100 million doses of Johnson & Johnson in June. I cannot understand why we weren't able to get between 30 to 40 million of those doses, which are going to be produced in Port Elizabeth and exported out of South Africa to the United States. Where were we when these decisions were being made? So this is unbelievable, and I think that we could have had all of our doses this year, and they're going to be in South Africa, but they're not going to be in South Africans. That to me is a problem.
Prof. Mushabela, what can we do to slow down the third wave?
Thabo, I think that we have to recognize that the difficulty of slowing down the third wave is not only about the epidemiology of the disease or the public health issues concerned only. The biggest challenge is the fact that society needs to function. And a lot of the decisions that are being made are made taking that into account. And it does mean that we have to make compromises if we want to really slow it down, a lot of compromises. And it starts with us appealing to all South Africans to be able to use masks and to distance and to avoid gatherings as much as possible. And I know people are tired of hearing this, but this is how we save lives. It's important, of course, that we continue to expand the vaccination program, and people have to take those jabs in order to make sure that in time the numbers will grow enough for us to be able to continue as normal as possible. But for now, Thabo, we really need government to engage South Africans in appealing for people to individually and collectively do what they can in terms of following these public health measures. That's all we have at the moment in terms of prevention until we've got enough coverage of vaccines.
Prof. Linda, with your experience, I mean, in fighting HIV and TB infections, you, of course, are ideally suited to know the kind of work it takes to fight a virus. I mean, what would you say needs to happen?
Yeah, this is the tough one, and I hear my colleagues appealing to humans for human behavior change, and that's always hard. We've really struggled in HIV and we've struggled in TB, but the bottom line is until we have that prophylactic vaccine, we can deploy it, we really have no options but to rely on the 3 C's. So it's already been said, I'm going to say it again, you've got to be careful about crowded spaces, close encounters, and, making sure that we're wearing masks when we can, because fresh air is going to be our best friend. And obviously as we go into the winter, that always becomes more difficult. So I'm holding thumbs that those vaccines do begin to appear on our shores. We on the sort of vaccination side will do our utmost to get them into arms as quickly as possible. But in the meantime, it's going to depend on each one of us to remember what we need to do to reduce that risk. And, it's just asking for us to dig deep and keep doing it.
I appreciate all of you for joining us tonight. That is the co-principal investigator of the Sisonke study and director for the Desmond Tutu HIV Center, Prof. Linda Gail Becker, acting Deputy Vice Chancellor of Research and Innovation at the University of KwaZulu-Natal, Professor Musa Mushabela, and the Wits University Social Security Systems Administration and Management Studies Chair, Prof. Alex van der Heever. And thank you for your messages tonight and engaging with us in this conversation. When we continue next, we speak to Section 27 as well as the Center for Child Law ahead of Human Rights Day. There are concerns of continued neglect of children's rights in the country. They'll raise those issues with us in the next hour. Stay with us.